Welcome to the latest presentation in the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. There we go. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. So a few tips before we get started. Your audio has been muted. Please use the question and answer function of Zoom platform to ask questions. Questions will be answered at the end of the presentation. Today's webinar is being recorded, and you will be able to access today's and past webinars on the National TRC YouTube channel. So today's webinar is hosted by the Center for Connected Health Policy, which is the National Telehealth Policy Resource Center. My name is Christine, and I'm a policy associate here at CCHP. So this is just an overview of what we're going to cover today generally. We're going to talk about the national telehealth landscape and developments in the first quarter of 2018. I'm going to provide a summary of the changes made in the calendar year 2018 Medicare physician fee schedule. We're going to review some of the telehealth elements that were passed in the bipartisan budget bill. And then I'm going to share some general trends that we're seeing in state telehealth legislation across the nation. So let's go ahead and get started. So just for disclaimer purposes, anything I talk about today should not be considered legal advice. We always suggest that you contact an attorney regarding legal matters. And CCHP has no financial interests or arrangements with any of the products or organizations that I'm going to be discussing today. So just for a brief background about CCHP, we are an independent public interest organization that is dedicated to advancing sound state and national telehealth policies that promote better systems of care, improved health outcomes, and provides greater health equity of access. And we were formed in 2008 by the California Healthcare Foundation, primarily to look at revamping California's telehealth law. But then in 2012, we applied for and were awarded the grant to be the National Telehealth Policy Resource Center. And in that capacity, we provide free technical assistance to anyone throughout the nation interested in telehealth. And that can be people from providers to patients to health systems to policymakers and anyone in between. But we have a special emphasis on the rural and underserved and also the 12 regional telehealth resource centers. So when CCHP first became the National Telehealth Policy Resource Center, we did a state-by-state analysis of the policies, laws, and regulations throughout all of the states. And we chose about 12 category areas of interest in telehealth, mostly related to Medicaid reimbursement, but also related to private payers, licensing, prescribing. And all of that information can be found on our website through a PDF report and also through our 50-state map, which provides an interactive display of the laws and regulations. Our last update was done in October 2017, and I'll be referencing some of that information throughout this presentation. So let's get started with an update on Medicare. So before I talk about what's changing in Medicare, let's talk about what Medicare policy is. According to the Social Security Act, Medicare covers only live video. There is an exception for store and forward or the asynchronous sending of information in Alaska and Hawaii demonstration pilots. Medicare also restricts the list of providers who are eligible to be reimbursed. And they also have two restrictions on originating sites, and these are some of the most restrictive aspects of Medicare policy. First, they limit it to rural health professional shortage areas, non-metropolitan statistical areas, or telehealth demonstration projects. And the second condition is that the patient has to be located in some type of medical facility. They have a specific list of those types of facilities, but they include things like hospitals, physician offices, that sort of thing. So the patient can't be located in their home or the workplace or a school. And then Medicare also limits the types of services that can be reimbursed through live video. And they have a specific list that's updated once a year through the physician fee schedule. But it includes about 80 different CPT and HCPCS codes that can be reimbursed. This is just a sampling of them. And again, like I said, in the physician fee schedule, they usually add 3 or 4 codes to this list every year. But that's out of a possible 10,000 codes that are reimbursed in total in Medicare for fiscal year 2014. I'm sure it's more now. So just a very small segment of what's available can be reimbursed. This is that list that Medicare has that limits eligible providers. So that's the provider at the distance site. It must be one of these types of providers. You'll notice that some notable providers are missing, such as the allied professionals, physical and occupational therapists, for example. Also, on the right-hand side, you can see that list of the eligible facilities under Medicare. So you have things like hospitals, critical access hospitals, RHCs, FQHCs, but obviously the patient wouldn't be able to be located in their home. So like I said, the physician fee schedule that comes out once a year does add additional codes. And then a few years ago, the physician fee schedule also added reimbursement for non-face-to-face chronic care management. And those codes can include some telehealth services, especially remote patient monitoring. And because they do not fall under the definition of telehealth, the normal restrictions that I just talked about do not apply. But I'll talk a little bit more about the chronic care management codes and the conditions connected with that further down in the presentation. So for the 2018 changes for the physician fee schedule, it included the addition of more codes for reimbursement, including psychotherapy codes and then add-on codes for the administration and assessment of chronic care management services. It also included the removal of the GT modifier for the purposes of claims, and they are now only using the O2 place of service code. So that code indicates that the interaction happened over telehealth. CMS indicated in the physician fee schedule that they felt that the O2 place of service code and the GT modifier were duplicative of each other. And so you no longer need to use the GT modifier on claims except for critical access hospitals method 2 billing, and also for Hawaii and Alaska demonstration projects, because they can do the store and forward. So they need some way to differentiate between store and forward and live video. So the GT indicates live video, and then the GQ indicates store and forward. In the physician fee schedule, they also did a request for information on ways that telehealth could be expanded further, and they had a specific interest in expanding for remote patient monitoring. And they have indicated that they received quite a bit of comments on that, and they expect future rulemaking regarding this. But in the meantime, they have unbundled the remote patient monitoring code 99091. And like the non-face-to-face chronic care management codes, they are not, that code does not fall under the definition of telehealth, and so all of the restrictions related to telehealth do not apply for that code. And then the last thing that the 2018 physician fee schedule did was allow RHCs and FQHCs to bill that chronic care management code for services. So I'm going to talk a little bit further about the chronic care management codes and the remote patient monitoring code. So in 2015, Medicare did add the 99490 code for non-face-to-face chronic care management. That includes at least 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month. And the conditions include that the patient has multiple chronic conditions expected to last at least 12 months or until death. They do have a list of conditions that they think would qualify, but it's not limited to that list. They also require that the chronic condition place the patient at a significant risk of death or acute exacerbation, and that a comprehensive care plan has to be established, revised, and monitored. The eligible practitioners that can deliver these non-face-to-face chronic care management services include certified nurse midwives, clinical nurse specialists, nurse practitioners, and physician assistants. And a note about this is that advanced patient consent is required. And the services that can be delivered typically fall out of the face-to-face visit and focus on characteristics of advanced primary care. So some examples that CMS gives of services that would qualify include continuous relationship with the designated member of the care team, patient support for chronic diseases to achieve their health goals, 24/7 patient access to care and health information, receipt of preventative care, patient and caregiver engagement, and timely sharing and use of health information. So you can see it doesn't specifically talk about telehealth or remote monitoring, but you can see how some of the aspects would fit nicely in there. And then in the 2017 physician fee schedule, they expanded the reimbursement for these non-face-to-face chronic care management codes to include complex chronic care management. So they added the codes 99487 and 99489 to the list of reimbursable services. Again, none of this is subject to the normal telehealth restrictions in Medicare. And CMS has also released a toolkit to raise awareness about these codes because they have found that the utilization of them is far less than they were expecting. And so they have several pieces of information and fact sheets and tools on their website that you can access to learn more about the codes and raise awareness among providers and patients about them. So then there's also, like I mentioned, in 2018, they've now unbundled the remote monitoring code 99091. And that CPT code is defined as the collection and interpretation of psychologic or physiologic data digitally stored and or transmitted by the patient or caregiver to the physician or other qualified healthcare professional. And it's about 30 minutes of time, minimum of 30 minutes of time. So you could see how remote monitoring really fits into this definition provided for this CPT code. So some requirements associated with 99091, you do need advanced patient consent to bill for it. A face-to-face visit is required first. An annual wellness visit or physical would count for that. It can be reported no more than once in a 30-day period per patient. And the service must include the physician or other qualified healthcare professional involved with data accession, review, and interpretation, modification of the care plan as necessary, and associated documentation. And it can be billed once during the same period as a chronic care management service or transitional care management service or behavioral health integration services. And again, just like for the chronic care management code, the Medicare's typical telehealth restrictions don't apply for this code. So now I'm going to talk about some of the changes coming to Medicare as a result of the passing of the bipartisan budget bill. There were a few telehealth elements that were slipped in there. So one is related to Medicare Advantage plans. A lot of people ask, what about Medicare Advantage? Do they still have to comply with the same restrictions that apply to general Medicare? And the answer is currently yes, but they can offer, go above and beyond what Medicare allows for through offering a supplemental plan to their beneficiaries, but their beneficiaries would need to pay for it out of higher premiums or rebates or additional copays. But now with the passing of the bipartisan budget bill, beginning in 2020, Medicare Advantage plans will be allowed to provide additional telehealth benefits, and those benefits would be treated the same as Medicare fee-for-service, Part B option. And the normal telehealth restrictions would not apply. It would also allow for other services identified as clinically appropriate to also be included within those telehealth benefits. And the way that they would determine that is that the Secretary would solicit comments on the types of telehealth services that should be considered additional telehealth benefits by November 30th, 2018. And then the Secretary will also need to establish requirements around physician or practitioner licensure, care coordination with in-person services, and then any other areas deemed necessary by the Secretary. So the impact of this section is really going to depend on how the Secretary defines additional telehealth benefits, and then whether or not Medicare Advantage plans decide to take advantage of this option and offer those additional telehealth benefits to their beneficiaries, because it's not a requirement in the bill, they're just allowed to. The second area of the bill related to telehealth that it covered is accountable care organizations. So according to the bill, beginning in 2020, ACOs will have the ability to expand telehealth services to include the home as an originating site and eliminate those geographic requirements. There are similar waivers currently made in the next generation ACO model, as well as the comprehensive care for joint replacement model. So this bill would just extend those same waivers to all Medicare two-sided ACOs beginning in 2020. And then the Secretary would be required to conduct a study on the utilization and expenditures for telehealth by those ACOs no later than January 1st, 2026. So again, the impact of this section will really depend on if the ACOs choose to take advantage of this option to offer telehealth services to the home and other areas that they wouldn't ordinarily qualify for. Because again, it's not a requirement that they do so, it's just the ability to do so. And then the last area that the bill looked at is adding additional originating sites for the purposes of treating acute stroke and end-stage renal disease visits. And so these new originating sites would be exempt from the rural geographic requirement in Medicare, but they would not be eligible for the facility fee. So you can see the new originating sites for each of the associated conditions listed here. The ones with the asterisk are ones that are not currently on the list of eligible originating sites under Medicare, but all of these sites would be exempt from that geographic requirement when it comes to treating these specific diseases. And then there's also a few pieces of legislation that are proposed still out there. There's HR 2550, the Medicare Telehealth Parity Act, HR 2291, helping expand access to Rural Telemedicine Act, the HART Act, and then the Telehealth Enhancement Act. And I'm not going to go through each of these individually. CCHP does have an analysis of each of these on our website, but you can see just from the bullet points that they all seek to expand reimbursement in Medicare somehow, some by eliminating that geographic restriction, some by adding additional originating sites. Some allow for the FQHCs and RHCs to act as a distance site provider. That's been one of a main barrier that FQHCs and RHCs face when it comes to telehealth. So unfortunately, a lot of these, or all of these bills were introduced in 2017 and hasn't seen much movement in 2018, but hopefully we'll see progress here soon. And then some other federal developments to be aware of. There is proposed regulations for the Veterans Administration to allow VA providers to treat VA eligible beneficiaries from anywhere no matter their state of licensure or whether or not they are located in a federal facility. Currently, VA providers and patients need to be located in federal facilities in order to treat a patient that's not located in the state that the VA provider is licensed in. So this would allow a VA provider or VA patient to be located anywhere and still services provided as long as the provider is licensed in one of the US states. So this is a proposed rule. I checked on it this morning and it's still in the proposed status. There's also 2 pieces of legislation aimed at this, as 925 and HR 2123. And I have hope that this will get passed this year because there seems to be a big push behind this. And then there's the issue of prescribing. So prescribing is usually regulated on the state level, but when it comes to controlled substances, there is a federal law, the Ryan-Haight Act, which governs it. And it essentially limits the prescribing of controlled substance, that initial prescription, to happen either at an in-person visit, or it can happen through telemedicine if the patient is physically located in a hospital or clinic registered with the DEA. The telehealth provider, the one that's issuing the prescription, must also be registered with the DEA as well in order to issue that prescription over telemedicine. The DEA is allowed to create a special registration process for the prescribing of controlled substances without that in-person exam under certain circumstances. But they've been talking about doing that for a few years now, and it's not happened quite yet. I'm hopeful that it may happen soon. There seems to be a push around it, mostly as a result of the opioid epidemic, but we'll see what happens. There is a draft bill that's circulating currently from Congresswoman Matsui's office, the Improving Access to Remote Behavioral Health Treatment. It's what it's called, and that would require the DEA to register community mental health or addiction treatment centers as eligible patient sites for the initial controlled substance prescription. So that would open up reimbursement, at least a little bit, for controlled substances. So then there's also the Federal Communications Commission. They've been active in telehealth, mostly related to the Healthcare Connect Fund, which offers funding for high-speed broadband to eligible rural healthcare providers. It's a 65% discount. And they've recently expressed a desire to increase the funding available through that program just because it's been in such high demand. And then recently, they've also launched a Connect to Health FCC task force in order to raise consumer awareness of the value of broadband in the healthcare sector for patients. So they're very committed to that. But then I'm sure you've all heard about the rollback of net neutrality, and there has been some concerns raised about what the impact for that would be on telehealth, because there's some concerns that smaller rural providers may be priced out of high-speed broadband if the price gets too high. And while some exceptions can be kind of carved out, I'm sure, for healthcare facilities, it would be hard to extend those exceptions to the individual in the case that they are getting telehealth to the home in some way, either live video with their provider or through remote patient monitoring. So we'll just kind of have to monitor that and see where that leads. So then some activities of other federal agencies. There's the Office of the Inspector General. They have announced late last year that they're going to be doing an audit on Medicare reimbursement for telehealth. And the way I understand they're going to do it is to match up originating site and distant site claims to make sure that they're matching up with each other. So we'll see how that goes. I think their report is due out in 2019. And they're also going to be doing some research into Medicaid reimbursement as well to make sure that the payment for claims matches up with their state's reimbursement policies at the time. So then there is the Federal Trade Commission. And in the past, their activities has mainly focused around the regulation of telehealth by state licensure boards. And that mostly stems from one court case called the North Carolina Board of Dental Examiners versus the FTC. In that case, the Supreme Court ruled in favor of the FTC and found that the makeup of licensing boards can unfairly influence trade practices. So that can affect telehealth because of these telehealth practice standards being passed by the licensing boards. And in some cases, the FTC may feel like that's anti-competitive. So in response to an Alaska state bill a few years back, they commented on two elements of the bill. The first one they were happy with. It was regarding allowing out-of-state providers to provide services within Alaska as long as they are licensed in Alaska. Before that, you had to be physically located in Alaska to prescribe within the state, even if you were licensed in Alaska but located somewhere else. And so the FTC commented that they liked this and that they thought that it would create better competition, cost savings, and more options for consumers. But then on the other hand, they raised concerns about another part of the bill that directed the medical board to create telehealth practice standards, and they questioned whether it was necessary to create a different standard for telehealth and in-person services. And then they also were involved in another court case called the Texas Medical Board versus Teladoc. And they just actually opened an investigation into the Texas Medical Board due to the lawsuit. It was an antitrust lawsuit, but that dispute was decided out of court. It was decided through a compromise in the state legislature with the bill, and so their investigation into that case got dropped. And then just last month, the FTC issued another comment letter in regards to Washington state legislation, SB 5411 and HB 1473. Those are companion bills. And the FTC voiced concerns about a requirement in that bill for an in-person visit in order for the prescription of eyeglasses or contact lenses. In their letter, they expressed concerns that whether or not it was really necessary for that in-person visit in order for that prescription to be made, and they thought that it may be anti-competitive. So now I'm going to move into some state policy trends. So CCHP has been tracking approximately 167 bills this legislative cycle, so it's been quite active, and this is just a rough breakdown of the topic areas covered by the bills. You can see that pilots, demonstrations, studies are still quite popular for telehealth legislation. Then we have Medicaid reimbursement and private payer laws. They make up a big percentage here. And a lot of that legislation is not new laws being proposed, but rather revisions to laws that have been passed in previous sessions, but perhaps there hasn't been as great of adoption in the state as states were thinking, and so they're going back and looking at how they can further strengthen their bills in order to encourage greater adoption. And then we have a few bills related to those telehealth practice standards and establishing the physician-patient relationship and prescribing, and I did break out workers' comp in here. Because we've seen a few bills crop up on that, and that seems like it might be starting as a trend, just basically to extend some of the reimbursement requirements in private payer bills to also cover workers' comp plans. So this is just to give you a flavor of some of the bills that are out there right now. We have California Assembly Bill 2861. It requires the state Department of Healthcare Services to reimburse for substance use disorder services provided through telehealth. We have Connecticut House Bill 5152 that creates an exception to Connecticut's requirement that no provider is allowed to prescribe a controlled substance through telehealth, and it creates an exception for medication-assisted treatment of substance use disorders. So you can see a trend here between these two of the opioid epidemic or substance use treatment driving some policy here. Then we have New Hampshire House Bill 1471. This is a payment parity bill requiring the same rate of payment for telehealth versus in-person services. So states have struggled with this a little bit. Last year, we had quite a few states introducing payment parity bills, but very few got passed. CCHP has actually only identified 3 states that currently have explicit payment parity in their law currently. Those are Hawaii, Minnesota, and Delaware. So then we have Kansas, House Bill 2674. This bill establishes telehealth practices for the use of telehealth in the state, and also parity between in-person and telemedicine delivered healthcare. So this is one of the states that don't have previous policy related to telehealth, or at least very little, and this is a new parity bill, kind of an all-encompassing telehealth bill that's being introduced. States in a similar situation include Pennsylvania and South Dakota. Then we have Minnesota, House Bill 2919 and SB 2765. These bills allow community health workers to provide telemedicine services and eliminates their Medicaid requirement that limits telemedicine encounters to no more than 3 times per week can a telemedicine encounter be billed. So that would eliminate that requirement for the delivery of services related to infectious diseases. And then we have Hawaii Senate Bill 2718. That specifies that a physician-patient relationship or bona fide advanced practice registered nurse-patient relationship may be established via telehealth. So that's one of those bills related to prescribing and licensure board standards. And then we have Illinois House Bill 5473, and I picked this out because I thought it was unique and interesting. It requires private insurers to maintain provider directories that include whether a provider offers the use of telehealth or telemedicine to deliver services, and some related descriptive things related to that. So that's kind of just an overview of some select example bills that I picked out, but some other general themes that I've noticed. There's a push in many states, especially Medicaid programs, to allow schools to be eligible originating sites. There's also the issue of prohibiting insurers from limiting reimbursement to specific technology. We've seen that in some states when a parity bill gets passed and an insurer wants all of their telehealth to go through a certain vendor. And so these bills are starting to be introduced to limit that. There's also legislation and regulation mostly around allowing telehealth to meet network adequacy or timely access standards. And then a lot of the pilots and demonstration projects that we're seeing bills for incorporate telehealth into substance use treatment programs in some way. So those are some of the trends. And then I thought I'd just quickly talk about the licensure compacts that are out there. I've seen 16 states this legislative session that have bills related to cross-state licensing, mostly related to the compacts. So just to give you a brief description, the Interstate Medical Licensure Compact is currently one of the most popular ones because it's for physicians. It's not a multi-state license, as many think. It's an expedited licensure process. So you still need to apply for separate licenses in each state that you want to practice in. It's just supposed to be a faster process, less paperwork, and less costly. So far, 20 states have adopted the legislation. And in order to do that, states need to adopt certain legislative language in order to join the compact. Other compacts that are out there include the Enhanced Nurses Licensure Compact. That's the one that's been around for the longest time. And then there is the Physical Therapy Interstate Licensure Compact, which is just getting underway. They're actually still forming their governing committee, and they plan to launch it in July of this year, I believe. And then these are just some resources for you. CCHP's website, that's where we have our 50-state compendium of laws, regulations, and then there's the Telehealth Resource Center website. And this is just my contact. If you have any questions after the presentation ends, you can email me those, but I am going to take questions here shortly. And but first I'm going to do some kind of closing slides. First of all, just so you all know, there is a webinar series happening March 26th and 28th, which is an introduction to utilizing Telehealth Connect, which is a tool created by the TRCs to help better understand the telehealth provider landscape across the US. This is the link to register. I know it's quite, might be quite difficult to take down, but I think it will be available through the TRC website shortly. And so this presentation has been part of the National Telehealth Resource Center's webinar series. The next webinar is scheduled for April 19th and will be presented by the Southwest Telehealth Resource Center. Registration and further information will be sent out shortly. And we value your opinion and ask that you take a few minutes to complete the online survey. So thank you for having me here today, and I'll just take some questions now. And I wanted to start with some questions that were submitted before the webinar through email. And the first question is there an official website or resource for updates on the compact? And there is. That website is imlcc.org. They also ask if the governing board has been put in place for the compact and is in operating condition, and the board has been in place. It's called a commission, and I believe each state gets 2 representatives who have joined, and states are actually issuing licenses already, at least some of them. And then related to that, they also ask what the current license is being allowed to operate under the compact. So for the physician's licensure compact, it's only for physicians. For the nurses compact, it's only nurses, RNs. There is a advanced practice registered nurse compact that they're trying to create, but it hasn't been passed by enough states yet. The physical therapy compact only applies to physical therapists and physical therapy assistants. And then there's also a psychology interjurisdictional compact out there, but that also has not gotten enough states to participate in it or not. Another question asked how an institution can become a telehealth consulting entity. Are there some case studies? So I would say a great place to start with that is your regional telehealth resource centers. They can get you started and provide you with some resources that you would find helpful. And then this question asks about what services are reimbursable for telemedicine and Medicaid, specifically for telepsych. And Medicare does have a telehealth booklet where they list all of their HCPCS and CPT codes that they'll reimburse for, including the telepsych codes. So you can, if you just simply Google telehealth Medicare booklet, it's the first thing to come up. So you can find that list there. And for Medicaid, each state usually has their own Medicaid policy related to telehealth where they outline what services are covered. And a good place to start with that is CCHP's website, because we try to link all of our policy information to the Medicaid manuals in each state. So you could start there and link to the Medicaid manual that's most appropriate and see what their policy is. So now let me look at some of the other questions. Let's see, is the main distinction between remote patient monitoring and telehealth the fact that RPM is not face-to-face or live video, or can RPM ever be via live video? Yeah, I think if RPM was via live video, it would fall under that telehealth definition. So for Medicare at least. So, so all those telehealth restrictions would apply. Thanks, I thought that Medi-Cal no approved and reimbursed for store and forward teledermatology. and teleophthalmology. Yes, that is true. Medi-Cal does reimburse for teledermatology and teleophthalmology. That's the Medi-Cal program, so the Medicaid program in California itself. Also, is there a way to get a written copy of the transcript? I'm not sure if we provide a written copy of the transcript, but the webinar will be available on the Telehealth Resource Center website. It's archived, so the video will be available on the YouTube page as well. The O2 modifier change reimbursement for non-facility distance site providers. Does the Medicare have any plans to reconsider this reimbursement change to allow non-facility providers to be paid? Okay, to be paid at the MPFS rate. I've heard this issue come up before, and I believe that Medicare has said that they're going to take a closer look at this. I'm not sure what their plans are to resolve the issue, but I think they are aware of this issue. If an existing physician practice enters into an agreement with a telehealth company, the telehealth providers need to be credentialed with the existing physician practice and reassign their benefits with insurance companies in order for the existing practice bill for services, correct? Yeah, so physicians at a distant site do need to become credentialed and privileged at the originating site. There are CMS regulations that allow for this to happen through proxy, credentialing by proxy. But not all facilities do this. It's an option. So that is definitely something that you need to consider. If an existing practice enters into an agreement with a telehealth company, oh, I think I just did that. Let's see. How can we get the chronic care management codes be added to Medi-Cal for RHCs and FQHCs? Medicare pays, but Medi-Cal's medical states they will not pay for these. Oh. So yeah, that's another question about the California Medicaid program. California Medicaid does seem interested in expanding reimbursement for telehealth to the home. They have not expressed a desire to reimburse for any type of remote patient monitoring at this point that I know of. But it would be a good idea to bring the idea of reimbursing for those chronic care management codes to them. They seem more open to reimbursing for things that Medicare already covers. So definitely a good approach for the Medi-Cal program here in California. How do we get the insurance companies to accept these codes and telehealth as telemedicine grows and additional codes are created for reimbursement? In New York, most insurance companies do not want to contract or reimburse for telehealth services. So I think that getting insurance companies to reimburse for more codes will just come with time. Some of the parity legislation that's out there does allow insurance companies to set limits on what they'll reimburse for and what they won't. Other legislation is a little stronger and requires that if it's delivered in person, that it also has to be covered through telehealth. So that's one strategy, but also just education of the insurance companies and the realization that they're not going to lose money off of expanding reimbursement. Can CPT, well, it keeps changing on me. Can CPT 99091 be billed under a bundled payment model with the practice receiving reimbursement, or would billing the code simply be counted towards the cost of the episode of care? I'm not sure about the answer to that question. Feel free to reach out to me through my email, christinec@cchpca.org, and I can research and look into further that question. Currently, can a Medicare beneficiary with a Medicare Advantage plan receive a CCM service from a provider other than their PCP? I'm also unsure about the answer to that question. I know that CCM services need to be delivered by specific professionals, and I would assume that Medicare Advantage plans need to follow the same rules as Medicare, so probably whatever applies to general Medicare also would apply to Medicare Advantage. But if you want to follow up with me after, I would be happy to look further into that as well. Do you know if the commercial plans reimburse for 99091? I don't know that. Usually commercial plans are, they don't share their telehealth reimbursement policies or general reimbursement policies with the public. Usually it's negotiated between the providers and payers. So I don't know the answer to that question. Since it's just newly being reimbursed by Medicare, I would guess that reimbursement probably is kind of limited on the private plan side, but I don't know for sure. Can we follow up? Can we see follow-up patients for our outpatient suboxone clinic via telehealth? Their initial prescription would have been given at the first visit. So I assume that this has to do with the controlled substances law, and I think there is kind of a gray area for the prescription of controlled substances after that initial visit. So I can't say this, because I'm not a lawyer, I can't say that you can do it, but I do think that that's a gray area in the law. Where does the insurance industry, large employers, and various medical societies stand, generally speaking, on the presented legislation proposals? It varies. Insurance companies just vary on their stance. Some are very supportive, some create opposition. Large employers tend to be more supportive because they see the value of telehealth for their employees. It helps them not miss work, for example. So it just varies. For mental health, can you see a client in a different state? If you're licensed in that state, normally you can, but if you're not licensed in the state, the telehealth encounter occurs at the physical location of the patient. And so you need to comply with the laws and regulations of the patient's state. So most of the time, states require that you be licensed within the state. Changes to Medicare Advantage plans under the Budget Act. Could you please give a concrete example of what would be different under the new rule? Perhaps share a telehealth service that might be added. So like I said, that for Medicare Advantage, it adds all Part B services without those telehealth restrictions. So anything currently offered under Medicare Part B would be added. And then in addition, it's saying that the Secretary would issue a call for comments for some additional telehealth benefits that might be included. I'm not quite sure what they're thinking, but probably things that don't maybe have an in-person equivalent, perhaps some of those remote patient monitoring services. We're just going to have to kind of wait and see to see what they come up with. Currently, can a Medicare beneficiary with a Medicare Advantage plan receive CCM services from a provider? I think I already answered that question, and I said that you can follow up with me and I can do some further research into that. Let's see. What commercial insurance companies are currently billing for telehealth behavioral health services? Again, we don't know the specific reimbursement policies for all the commercial insurance plans. They tend not to share that information publicly. Is there a list of insurance that are covering telehealth for nutrition? Again, we don't know that information. Are participation agreements or telehealth compliance certification required typically? No, There are a few states that require participation in a telehealth network. For example, Kentucky requires, in order to participate in their Medicaid program through telehealth, you need to be part of their Kentucky telehealth network. I think Minnesota has a requirement in their Medicaid program that you agree to follow certain criteria or restrictions that they have, but there's generally not some type of telehealth compliance certification, but it varies by state. So you would want to check with your state, whoever you're getting reimbursed from, and also your medical boards or licensing boards. Is there a way to add Medicaid to bills services at Puerto Rico? I'm not sure about this question regarding Puerto Rico. Again, if you want to follow up with me over email, I can do a little bit of research into that. Any movement on RPH reimbursement for telehealth? I'm not sure what RPH means. So again, if you want to follow up with me, I'd be happy to talk about that over email. Does the law allow access for behavioral health providers impact the geographic areas where telehealth meets restricted access requirements? I'm not sure I quite understand the question. So if you again want to follow up with me, I would be happy to talk with you further about that. I was looking for the reimbursement schedule for Medicaid in California. I can't seem to find the link on the website. So Medi-Cal does have a provider manual on telehealth for the California Medicaid program. It should be available through our 50-state map if you click on California and the Medicaid policy area. It also is available if you just Google Medi-Cal telehealth provider manual, and it usually just provides the CPT codes that they'll reimburse for, and then you'll have to access the physician or the fee schedule for Medi-Cal to look up those codes to see how much they reimburse for that. But if you want to reach out to me after, I can help you locate that information. I am new to telehealth. Thank you so much. Well, thank you, Mary. I'm glad that this was helpful for you. Who to contact to get Medicare to accept home as an originating site? So for Medicare, their policy is in the Social Security Act. So they are limited to only allowing for reimbursement for those specific originating sites that I listed. In order to allow the home to be an originating site, it would require a change in law. So that means legislation. So probably the person to contact is your state legislators. Write letters to let them know that this is necessary. If a patient is seen via telehealth at a skilled nursing facility, does there have to be a face-to-face encounter by the physician within the tax ID of the distant site provider? I'm not sure about that answer. Again, if you want to follow up with me, feel free. It sounds like as of now, there is no compact for behavioral mental health. So there is that compact out there for the interjurisdictional psychology compact. Again, there's not enough states that have joined quite yet. I think they're hopeful that they'll get more states. It probably requires at least 7 states to join. So once that happens, it can come into existence. But if you want to follow up with me, I can give you more information about that. What are the 16 states with, I assume that you mean telehealth legislation. If you want to follow up with me, I can email you that list of 16 states with legislation related to the compacts. Can a New York State licensed physician work from California, seeing their New York State patients via telemedicine? If you're licensed in New York, usually that would probably be okay. You would probably want to check with the New York Medical Board just to make sure. Also the California medical board. But usually, as long as you're licensed in the state that the patient is in, you should be okay. Can you perform a telemedicine visit in the home and be reimbursed as an office visit without the originating site fee? So, I mean, for Medicare, you cannot deliver telemedicine services to the home. In Medicaid, in Indiana, I don't know offhand what their policy is for the delivery of services in the home, but if you want to follow up with me, I can provide you some further information on that. Is there a compact for clinical social workers, mental health? Would that fall under the psychology compact? I think it would. I don't remember offhand the specific professions that fall under that, but again, if you want to follow up with me, I can get that information to you. And I think this is going to be my last question, as the webinar time is wrapping up. Here we go. Do you know how many state Medicaid currently reimbursed for therapy services? Texas does not. I do not know offhand. In our 50-state analysis of telehealth laws and regulations, we did not go into the detail to research which states reimburse for certain professions. If you take our 50-state PDF report and do a word search for therapy, for example, you could probably find the states that explicitly list the therapy professions within their Medicaid policies for telehealth. But there might be other states that would be missing, such as states that just say we reimburse everyone in the healing arts, but they don't specifically list out physical and occupational therapists in their manuals. So we don't quite have the information available. If you want to contact me offline, I can try and pull that information together for you, at least for states that explicitly state it in their manuals. Okay, so I think that's all we have time for. I see that there's more additional questions, so if you guys, if I haven't answered your question already, then you can feel free to contact me and we can talk about it offline. Again, my email address is christine@cchpca.org. Let's see, I can go back. Here's my email address. Everyone, feel free to contact me with your questions. Thank you so much.